Welcome to Healthcare Rounds. I'm John Marchica, your host and CEO of Darwin Research Group. I'm excited today to bring back a returning champion, Dr. David Radley, also a buddy of mine going back to our Dartmouth days. In fact, I believe, Dave, you were one of two people, Trafford also, who was on a couple of weeks ago, who showed me around campus. So that's that's how far back we go in the Dartmouth world. So thanks for taking the time. Really appreciate it.
Yeah, absolutely. And yeah, I remember that day where Trafford and I brought you around. And I'll be honest, maybe Trafford said the same, maybe he didn't, I don't know. But we get these anonymous emails and they basically start along the lines of, "Hey, do you want a free meal?" And we're in grad students, so of course we want a free meal.
Yeah.
I'm glad I did it because we became friends because of it. So anyway,
Yeah.
glad to be here.
Yeah. So great. Let's dive right in. You've got a new or relatively new role at the Center for Evidence-Based Policy. And so today I want to talk a lot about data, but I thought a good way to start is just tell us a little bit about the new role, how you came to it, sort of what you're focused on.
Yeah, thanks a lot. So I've been at the Center for Evidence-Based Policy for a little over 2 years, so it still feels fresh, sort of. But it's a really neat place to work. So the Center for Evidence-Based Policy has been around for about 20 years, and it's an organization that started with the mission of really supporting state Medicaid agencies in helping Medicaid agencies and maybe in other agencies within state government to a degree make decisions using as much evidence and information as possible, really. And so often policymakers, especially policymakers they work in agencies or I'm not talking politicians. I'm not talking sort of like that level. I'm talking the people that actually have to sort of, make the sausage every day. That's hard work. And those individuals, sometimes they've got some staff available that can help them do some data analysis, but a lot of times they don't, or even if they do, they don't have the amount of capacity that they need to sort of to do all of the different analytic or evidence work that they would like to be able to do. And so the Center for Evidence-Based Policy sort of came around recognizing that this was a big gap for state policymakers in Medicaid, and has tried to fill that gap over the years by providing, evidence on particular medical treatments or particular pharmaceutical products, so that states can make the best decisions that they can with limited resources. And so, we have a full-time staff that a lot of whom spend time doing evidence review and giving that information back in the form of reports, how effective particular drugs or particular medical therapies are. Where do these products or technologies sort of fit into the payment landscape, for example, for Medicaid agencies, answering policy questions, answering technical questions about the therapies. About 3 years ago, our director recognized that more and more states are asking for help with analytics, with data analysis. And up until that point, most of the work at the center was really based on doing evidence review and synthesis off the evidence. Trying to sort of fill that gap, she was looking to sort of expand the work at the center, and so that she could offer, her people who she views as her partners, in states across the country, more help with the analytics. And so we got connected, and I was enthusiastic about the opportunity to sort of, move into a role like this. I think Medicaid is a hugely important health care program. And I was happy to sort of have a role working with Medicaid in so many states. I mean, we work with, since our inception, right now, I think we're at about 32 states, but since our inception, We've worked with over 40 states all across the country. Just helping people who love their work, people who are highly dedicated to the mission of Medicaid, helping them, by giving them as much evidence as possible to make the best decisions they can.
Yeah, Dave, my experience with folks over the years from Medicaid is exactly as you said. They seem to be very dedicated people. They're certainly not, doing policy work at the state level for the money, right? So they're very dedicated people. My concern really is about the loss of data, and I know we may be premature on this, but when I started seeing all the cuts to the grants, and look, you and I going way, way, way back to our Dartmouth days and the data sets that were kind of staples in the program that we'd go back to again and again. Some of those things were built over years. What was the one? Was it the women's health study that they had killed and then brought back? But talk a little bit about the data gathering process and maybe what your concerns are around the loss of having this kind of these ongoing studies that we may not have, and then trying to start them back up again.
Yeah, well, goodness. So I do think it's important to distinguish sort of the data collection apparatus that happens in academia from the one that happens as part of the federal agencies, sort of, as part of their mandates and their missions. That happens more or less through either their own efforts or through the efforts of their contractors. And I know more about the latter. In terms of the academia, there's a lot of, we've all heard in the news, there's a lot of funding cuts, particularly at places like Harvard. Those are going to be devastating in terms of the generation of science and the generation of knowledge. Let's put that aside for a minute, though. I think the areas where that sort of that I pay a little bit more attention to these days, that I certainly just sort of know more about is the sort of the wide wide array of federal data sets that we've had great access to over the last 15 years plus. So these might be, samples like things like the medical care expenditure survey, or MAPS. And we might be talking about things like the behavioral risk factor surveillance system, or BRIFIS, the National Survey on Substance Use and Drug Use, and SDUH. Some of these kinds of federal surveys that collect data primarily through survey mechanisms, some administrative data, but primarily through survey mechanisms that federal agencies have been doing as part of their mission. And I think those are the things that are at the most risk. They're at risk from sort of a couple of different angles. I mean, one is a particular data collection activity might simply be cut. I read last week that there's sort of a survey of surveys that's going around the federal government right now. I don't know a huge amount about it. This seems like it was a DOGE effort, where they were trying to sort of understand the value of different data collection activities that were happening inside of federal agencies. And so there's a possibility that a lot of these federal surveys will just simply be cut. We're going to move potentially from sort of this era of huge amounts of data of transparency because of data availability to an era of data scarcity. That scares me. The other thing that I'm scared about is particular data sets or particular data collection activities may carry on, and they may change in ways that aren't necessarily apparent. We might see, some examples that I've sort of read about in the news might be things like you're going to lose something like a gender indicator and replace it with a sex indicator. That's going to sort of alter, for people who are interested, in their ability to sort of use federal data to study issues related to people who understand themselves to be non-binary, for example. That's just one type of potential data loss. You might see similar kinds of sort of changes in response sets on race, ethnicity. I think that's the sort of the phase of this that I think we don't have a really great sense of just yet. A lot of the big federal surveys end up getting released late summer, sort of through the end of the year. And we have a lot of data from last fall, fall 2024. And when the next big sets of data releases come around again, we're going to see what ends up getting cut, what ends up getting changed. And I think we'll have a better sense for sort of the magnitude of potential data loss over the next, 6 months to a year from now.
My concern is, boy, I mean, we could talk on this topic for the rest of the hour, and we're not going to do that, trust me. But I'll say, on the one hand, there's things like you just mentioned, making sure that you're not checking for, or there's an option for gender, that it's just sex that's the variable that you're looking at. That, or in other things around diversity, so to speak. And just a blanket, hey, we're not going to look at these things anymore. Why is that problematic? Well, you and I have talked about this. I've talked about this on Healthcare Rounds a bunch. One of the things that we knew before COVID, but was really the Klieg lights were on it after COVID, were disparities in Black people, brown people, certain people with socioeconomic characteristics, disadvantaged people that were faring much worse. I think you wrote a paper on this, or at least your organization was looking at this, because I know we talked about it. And so that's an important policy, question and data that's important to gather, because look, if there's worse outcomes and we can do something better, right? As a policy person in healthcare, you want to do better. You want to bring those people up. And one of the things, we're in the middle of a pretty extensive national study on integrated health systems right now. This is in our world, so not the health system of the U.S., but more like IDNs, right? And I'm asking people about this issue, doing these interviews, and there's some concern about, the anti-DEI, or whatever you want to call it, sense that's coming out of Washington, confusing that with health inequities and things that, the healthcare system, broadly speaking, has been looking at for years and years and years. And it's part of the mission of so many healthcare organizations, taking care of addressing these health inequities. And so mixing DEI with, are you following me, Dave? Mixing these things up. And so just saying, okay, we're not going to do that study because it's a DEI study when it has nothing to do with DEI. Right. So are you sensing the same thing? Have you seen any of that? Or if not, are you as concerned as I am? Because I'm very concerned about this.
Yeah, I'm certainly concerned about it, John. I mean, who I don't want to say who wouldn't be. I guess there's probably people out there who wouldn't be. But yeah, I'm absolutely concerned about it. Disparity in the provision of healthcare, in the healthcare experience and health outcomes, it's not new. We've seen it for a long time, and it's not going away. And whether we pay attention to it, sort of, well, there's going to be people who are paying attention to it, and so I think we need to continue to use data as best as we can to continue to highlight disparities. The healthcare system only works as well as it does for the most vulnerable, and we need to continue to support the healthcare experience for vulnerable people. So I'm absolutely concerned. I think there is a difference between sort of what happens bedside in the way that clinicians provide care, and the way that policy priorities get set. And I think people that work in healthcare are going to continue to sort of do their best. Not that there's not disparity in the way that healthcare is actually administered. There absolutely is. But I think that some of the data collection activities we're talking about, there's not always sort of a straight line to what happens bedside. But there is usually a straight line between being able to measure disparity and where how things like disparity and equity get prioritized in the policy process. And if we're not prioritizing reducing inequity in the policy process, then it's only going to get worse.
Yeah. Yeah, that's my concern as well. So anyway, back to the center. We may come back to these other data issues too, but back to the center. My understanding is that you have a newer role that's not new at the center, but you have a newer role in data. And so I just wanted you to talk about, today, what are some of your big goals, things that you're trying to accomplish, and maybe some examples of some recent things that you have been able to accomplish at the state level that might be interesting to talk about.
Yeah, that's a great question. So, I sort of oversee a portfolio of data-driven work at the center that spans sort of lots of different areas. I think the thing that we have in, that the sort of the thread that runs through all of the data work that we do, it's that we're analyzing administrative data. If you want to come back to data, we should put a pin in it because I think administrative data is sort of unique in this data conversation. But pretty much all of the analytic work that I do at the Center for Evidence-Based Policy uses administrative data in some way to, again, help inform policy. So let me talk about a couple of different projects. One, we just completed a project called the Medicaid Evidence and Cost Review Initiative. We called it MERCI. And what that project was all about, we were using data from TMSIS. That's the big administrative data set that has claims from all of the state Medicaid agencies all across the country. They sort of get aggregated in one big data set, and you can see what kinds of health services Medicaid beneficiaries are getting in each state. And what we did in MERCI is we took a selection of pharmaceutical products that went through the FDA's accelerated approval process. Because states, a lot of these drugs, they're developed to treat very rare conditions, very serious. A lot of these drugs have huge price tags, and states are, if states are required, if the manufacturer participates in the rebate program, states are required to pay for these drugs for anything that's on the indication for these drugs. A lot of them are really helpful. So and they represent sort of new or the only treatment option for some of these rare diseases. Even, that said, if you complete value judgment aside, they still represent a big budget impact for a lot of states. At multiple millions of dollars per dose, for example. And so it's important for states to understand what the impact it might be for their state. So what we did was we used data from TMSIS to sort of estimate population prevalence for some of these rare diseases that are indicated by these accelerated approval drugs. And then we sort of mapped out, cost models. What might this look like over time for these states? What might their budget outlays be? How does that sort of work with the federal rebate? How does that work with the FMAP and the federal share? And what kinds of dollars are the states going to be on the hook for the selection of drugs? We looked at nine accelerated approval drugs. Really fascinating work. And so, I mean, I think the key takeaway from the sort of the body of work and is that, states, the diseases are rare, which is good. And states are still going to, potentially face challenges having to pay for some of these therapies. The costs are, for what it's worth, are pale in comparison to the costs that states potentially face on the GLP-1 issue. That's a whole separate issue. We didn't look at any GLP-1s, but I don't have to tell your audience on how important GLP-1s are going to be for state Medicaid agencies in terms of cost considerations. the other sort of big data project that we do, it's called the Oregon Child Integrated Data Set.
Hang on, Dave. Before you get into that, the way that I think about those high expense drugs, it's like on the one hand, going back to, what is it, 10, 15 years ago, whatever, the Gilead drug, and then all the ensuing Hep C drugs that addressed still a smaller, but certainly not a rare disease population, right? But a smaller population that budgets were blown open. And then you saw, like, I think it was at Oklahoma that went into a couple of those states, I think, went into value-based arrangements for those drugs. So that's one category. Then the other one is the really rare, like you said, no treatments, small patient populations. When you're looking at those two things, what were some of the results or some of the things that you've been finding in looking at that? Or is it premature?
No, I mean, it's not premature. I mean, I think the overall the findings sort of again across the body of work is that states are going to have to manage this. I mean, the in a way, like for example, we looked at TIVDAC. TIVDAC is a oncology agent that targets cervical cancer, if I have that right. We definitely looked at TIVDAC. Can't remember if TIVDAC was for lung cancer or for cervical cancer. In either case, it's for cancer, and like these cancers, they've been present in state Medicaid populations for a long time. Whether and so the states have been managing patients with cancer, and all of a sudden a new therapy comes along that might add a few months of life, may in some cases be curative in some way, or at least curative until patients sort of age out of Medicaid and into Medicare. And it's important for states to be able to sort of like understand what's the burden of a particular disease in their state. One of the diseases that's targeted by these drugs, and model that out sort of over the life expectancy either of the patient or their life expectancy during their time in Medicaid or until they age into Medicare. And so I think the takeaway is that states need to be thinking about these drug therapies as technologies that are going to have an impact on their budget over time. Our goal wasn't to sort of say, TIVDAC is good or bad. That wasn't our goal. Our goal really was to sort of help states understand, based on their population of sort of indicated patients, what is their financial burden going to look like over time?
Right. What's the expectation so that they can plan for it?
Exactly, so that they can plan for it. And so again, it's so the takeaway is that states need to be thinking ahead about some of these therapies. We looked at we looked at one. I forget the name. I'm sorry that I should have been. I didn't know we were going to go here. I would have sort of reviewed that. But we looked at a drug for SMA, spinal muscular atrophy, right? And what was the drug we looked at for that?
It's like two
right? Yeah, right, exactly. And again, what you're going to do is you're gonna target this drug on a kid who's under age 2, because a lot of kids that have SMA they die very early in life, and you're gonna treat this kid, and you're gonna hopefully keep them alive and give them a pretty reasonable quality of life over time. I mean, those are goals of any state Medicaid program. Fortunately, most states have less than 11 patients that would ever potentially get this drug, and so it's not a huge number of people. But each dose, each therapy, it doesn't come with high costs, and then there's going to be healthcare spending that happens downstream from that, just in terms of monitoring or different kinds of supportive therapy over time. The cost may shift. It may shift from certain types of inpatient stays to more intense, DME for at-home use or something like that. Or in the best case scenario, it might just sort of be monitoring with an expectation for less intense care over the child's, lifespan. But again, it is about planning. And so helping states understand what is your population for this rare indication look like? When does therapy start? How long does it last? What are the sort of the based on literature, what are the survival expectations once someone starts this drug relative to sort of traditional care, and how does that sort of fold into what you can expect your cost outlays to be? Because remember, the whole point of accelerated approval, it's not just that they're treating rare conditions, but it's that accelerated approval drugs often get approved with less evidence, less clinical evidence than drugs that go through sort of the full approval. And that's by design. Again, it's to get drugs for rare conditions onto market faster. The trade-off is that these drugs come to market with less of an understanding about how well they work or how long they're going to work for. And so we have to sort of take the evidence that's available, fold that into our cost model. And in some drugs, there's more evidence available today than there was when they were approved under accelerated approval. So we fold that into our cost model, and we try to just project that forward as best we can.
Yeah, and this is a long-standing argument, right, around accelerated approval. The people who need the drug or who want to have access to something, to a treatment, because they don't have anything, are going to be shouting from the rooftops. I mean, the best example of this precedes, I think, kind of both of us, some older than you, but early days of AIDS and HIV. And the tension between, okay, well, we have to do the right kind of studies and we have to get the people into the studies. And look, I think I've maybe even talked about this before on the show. Back in the day when I was just getting started at Abbott, there were protests because Abbott had an antibiotic that was not approved, but it treated certain type of pneumonia. I can't remember exactly what it was, but a certain type of pneumonia that was kind of the final straw for patients with AIDS. And Abbott was trying to do the right thing, I think. This is going back a lot of years, and I certainly wasn't privy to a lot of the decision making at that time. But there was this tension, right, between we want to get something to market, but then we want to make sure that it's safe. And then when you're dealing with small populations or populations of uncertainty, like COVID, right, or there's this trade-off. And I know that's not what you came on to talk about, Dick, but it's I think it's interesting. And if your work in some way can help inform that, I know you're not about whether or not something should be accelerated or not, but it's around the same kinds of issues. And I just don't think it's funny when things get to the Wall Street Journal and the New York Times and everything else, it becomes sort of an entirely different issue. Right around like, oh, the FDA shouldn't be approving these products because they're not well. And then you look at that patient population that's desperate for something, right? If they have that rare disease or, like you said, SMA. I mean, there was nothing. So
yeah, I mean, Jeff, but you mentioned it in that. I mean, what you're trying to do is manage the uncertainty, right? And regardless of what side of that uncertainty you're looking at, if you're a manufacturer, there's some uncertainty in whether or not there's going to be enough of a market to make our investment of energy and research and everything worthwhile. If you're a policymaker, there's uncertainty about, should I pay for this drug? If I'm not statutorily required to, should I pay for this drug or not? Is it going to give my patients good outcomes? If you're a clinician, there's uncertainty. You want to do the best that you can for your patients, and if there's not a lot of other treatment options available, should I try this one? And regardless, everybody in that sort of like model is trying in some way to manage uncertainty from whatever point of view they sort of are coming at it from. And I think that is the goal of what we do at the Center for Evidence-Based Policy, is we're trying to get as much information out to in our case, policymakers, and from that perspective, policymakers, to help them manage the uncertainty as best as they can, and maybe to a degree reduce that uncertainty by a little bit.
Yeah, I mean, and back to the Hep C example, I remember folks at the time saying, I remember being at a conference and it was somebody from an employer coalition that just said, look, if you just would have told us in advance, if you just would have given us a little bit of a heads up that this drug was coming and that a whole bunch of people were going to want to take it, then maybe we could have planned for it. So that goes back to that, managing uncertainty and tempering risk and all of that as well. So back to the center, you were going to give a second example of a project. So we're bouncing around a lot, but this is how our conversations go. So
this one's completely different. So as a tiny little bit of background, the Center for Evidence-Based Policy, it's housed at Oregon Health and Science University. That's the big public medical school in Oregon. That's where we were founded, and we continue to sort of live under that umbrella of OHSU. That's important context. Because the other big project that we do a lot of work with administrative data is we run a project called the Oregon Child Integrated Data Set. What this is, it's a collection of the administrative records for public services that children in the state of Oregon receive over time. So going back, we have data from about 2001 forward. So we get Medicaid data, we get data from the educational system, we get data from the juvenile justice system, from the foster care system, birth records, and we're aggregating all of this data, and we do research and analysis on this massive database, and that information gets fed back to policymakers in the state to again help inform their decision making. So we feed this. The reports that we write off of the data are public, but our target audiences really are agency, policymakers in the state of Oregon. And by policymaker, it includes agency staff, it includes legislators, it includes people in the administrative wing of the government in Oregon. And we look at a host of issues using this data. Right now, for example, we're doing some work to look at the sort of the intersection between behavioral health and juvenile justice. Really fascinating stuff. Really, we're curious. I think that the motivation behind the work is, Oregon has one of the higher juvenile justice contact rates of any state in the country, and Oregon knows this, and they've known it for a long time. And so there is some curiosity around where does sort of behavioral health fit into that picture, and what can we be doing in the behavioral health system to potentially even divert kids from landing into situations where they do come into contact with juvenile justice. All of that is sort of fresh and happening now, so there's not a lot to sort of talk about in terms of findings. That our work's ongoing, but over time we've done work on chronic absenteeism from school. We've done work on the experience of an early childhood among kids that are getting sort of multiple services. We sometimes characterize these kids as sort of being medically complex. They maybe have their young kids with multiple chronic conditions. They're getting a lot of help. These families are getting a lot of help from the state, and we want to know, does this help? That they're getting, does it matter? And do they have better reading scores at third grade, for example, if they're getting a lot of help between age 0 and 5? So that's just an example of some of the work that we've done on this, off of this data. Really fascinating stuff. And we're lucky to have this as a data resource in Oregon. And we're going to continue to sort of mine that as much as we can.
Well, and having,
can I say really quick, all of the data is completely de-identified. Anytime we're talking about administrative data, I want to make sure that I have that as a disclaimer. We do not see identifying information about the kids in the data set. We're still careful with the data. We do see things like what school the child goes to, things like that, but we don't see personally identifiable information.
And that's state level data.
It is state level data, yeah.
So you're in a way protected from, let's say, federal government mischief. Because what if that data set were to go away?
Well, it would be a big loss for the state for sure if it were to go away. I mean, it's protected from federal mischief. It's tough to say. I mean, we're sort of directly, probably yes. We have a fair level of a fair bit of protection, but indirectly, if if the federal government is thinking about ways to reduce the amount of support that it gives to states, that could sort of trickle down to something like the creation and maintenance of this data set in Oregon, even though it was set up by the Oregon legislature.
So I want to shift gears a little bit. We don't have a ton of time left, but a couple more topics. One question that I've been dying to ask you about, and that's around scorecards. And I know in your work with Commonwealth Fund, and you've done a lot of work with dashboards and data visualization. And I remember several years ago, you helped me at least think about visualizing our DVI, our Darwin Value Index, and getting that up on the web. And so my question to you is really around the value, how you see the value that these kinds of visualizations can bring to not just policymakers, but also consumers. When you're visualizing, this complex information, or you've given an example of rare disease, you've given and drugs in that area and analyzing that, and the example of what's going on with Oregon kids and behavioral health, and connection potentially issues with the juvenile justice system. But how do you take something like that? Like, I always think in terms of Excel spreadsheets, right? How do you take all of that and turn it into something that's usable for policymakers and for consumers? What is the value of that? And then also, I would say, what are the pitfalls in people misusing that information or not understanding it?
So, what's the value of this kind of sort of translation between sort of raw data to something that's consumable? I think there's so many ways to answer that, but really I think at the highest level, what the value is that it gets people to think about issues that they may not have thought about otherwise, and it gets people to ask questions. When a team of an analyst or a team of analysts gets set out to say, oh, I have this data set and I'm gonna try to answer some questions. The questions that they're going to be able to answer are narrow. They're narrow in scope for a lot of reasons. One, they need to be narrow in order to sort of make it, how to turn like an idea into an answerable question. They have to be narrow because of that person's perspective and everything they sort of bring to the sort of the research process. And those questions, as soon as you actually, and it's actually good that they're narrow, because if they're too broad, it makes the question unanswerable and watered down, and it doesn't help anybody. But when you can ask a focused question, when you can sort of make a compelling narrative out of the data, what that does is when you show it to somebody who may not have asked the same question, may not be particularly interested in the narrative that you derived. What you've done, though, is you've introduced them to the data. You've introduced them to a new way of thinking, and that's going to drive a set of questions that will ultimately sort of result in either more analytic activity or new sort of avenues for policy making. And so the value is using the data to get people to ask questions. To me, that's the value. It's way more valuable as a question starter than as a tool for actually answering questions. And so that's at the highest level. That's sort of how I approach it. I'm much more interested in sort of getting something good out there and in front of people and doing it in a sort of digestible way than I am about trying to figure out that I make everybody happy and answer everybody's question in this sort of one narrowly defined activity, which I know I would fail at if that were my goal.
Well, I asked that question in part. It's a little bit self-serving. Because we're undergoing here at Darwin, we're undergoing kind of a long process that I'm driving to write less, picture more. I don't know how else to say it, but my natural inclination, if I'm going to be, let's say, writing a paper, is to actually write the paper and with words, sentences, paragraphs, one leads to that kind of thing. But your point, I think, is really, really important in market research sense or in the work that you do, that sometimes a strong visual, a way of representing that information or interactively, where you can work with the information visually, can raise a bunch of interesting questions. And it can be a conversation starter for people to say, okay, well, I didn't thought of it that way, right? Instead of reading through paragraph. And that's not to say that it's not important to write papers and do traditional work in that area, but some of the data visualizations that I know that you've worked on have been pretty remarkable and have been very, very helpful. So I'm wondering how also in that process, though, that you make sure that people aren't misusing the information because it comes across in an infographic or in an interactive map, or how do you put the information out there in a way that, of course, it provokes conversation and ask questions, but isn't misleading?
Yeah, that's a great question. I mean, here's some strategies that we use. I mean, one, first I recognize that if somebody wants to sort of use information in a way that I consider misleading, there's probably not a lot I can do to stop them. What I can try to do is sort of divert that from sort of becoming a thing in the first place. And in some of the strategies I use, I try to use simple graphics. I think that a bar chart is the Swiss Army knife of data visualization and it should get used more often than it does. I think there is a tendency among some of the more techno-centric analysts out there to try to create really complicated visualizations that may look stunning in some cases, but a lot of time sort of confiscate or sort of confuses or creates the opportunity for sort of confusion in interpretation. I much rather go with very simple visualizations. I try to pair my visualizations with a paragraph that explains, here's what you're seeing. I love sort of the format of like a old school, so going back to chart packs. I love the format of a picture with a paragraph right next to it or right underneath it, that just sort of describes, here's what's going on in this chart, maybe a sentence about the implications of it, sort of depending on the focus of the piece you're working on. If you're going to do something interactive, I think you can incorporate that formula into interactive pieces too, using conditional logic and so forth, and sort of have different sort of text queued up, ready to go, depending on what selections are made in the interaction of the exhibit. To me though, and then I think the other thing that is super critical is, I think you have to have the right people doing the work. And right people, what I mean is you have to have an analyst who's actually driving the work that understands the context that work is going to fall into. You can have all the technical people on the side that you want, right? But you don't want to let decisions get made by the technical people who've got a really good technical skill, who may not necessarily understand a lot about the environment that the visualization or the tool that you're creating that it's going into. You really need that analyst to be driving the substance. And so, because I think the more the analyst knows, the less likely that they are to sort of create something that's going to sort of lead viewers down a path of confusion, because they're going to sort of know how to position it, right? And so to me, that probably is you have to start at the right place, and if you start at the right place, then the technical stuff can sort of come in behind it.
So one question that I've been asking a lot is around AI. Obviously, it's been we've been talking about AI for several years, but I'm curious from a researcher's perspective. Are there tools now? Because in the sense generally of some of the tools that you use, but are they working their way? And maybe it could just be ChatGPT for brainstorming, but are these sort of AI tools working their way in to your work, or are they still sort of on the periphery?
Yes and yes. They're on the periphery, and I see that having a much bigger impact, in the future. I am admittedly a little bit of an AI skeptic, and it's not because I don't believe that technology is good. It's that I'm so much of what I do in my world, particularly on administrative data, and I've talked a little bit about I am this data is all private. It's about people, and it's the data itself is private, and I have data use agreements that tell me who I can and can't share the data with, and how I'm allowed to interact with the data. And I still don't have a good sense for how AI and data use agreements on personally identifiable healthcare data actually interact with one another. So, what I've done to sort of avoid that is I've avoided putting healthcare data anywhere near an AI model because I don't want to have some sort of liability on me that I don't understand. That said, I have tried some AI with some public data, and I'm just being honest, I've gotten mixed results, but I think there's potential. Like, I was preparing for a conference last week, and I was just trying to sort of use AI in an example to say, there's this public data set that's out there. It happens to be a federal data set. And, can you help me sort of understand what's different from one year to the next in this federal data set? And the AI tool that I was using gave me some nicely crafted sentences about things that I should be considering if I'm looking at data, considering sort of how different. And I wasn't even looking at like point estimates. I just sort of wanted to know about the data set itself. How did the data set change from one year to the next? And so it gave me some sort of interesting perspective on things to look for. And at the same time, it also told me that both years of the data set had the same number of observations in it, which is a huge red flag. A, it wasn't true. I know it because of the data that I use. And B, it would never be the same, 2 years in a row. That just would be weird. So I was a little cautious when I called out the AI tool that I was using. Said, "Hey, you told me X, but the reality is actually Y." It said, "Ooh, sorry." Like it literally said, "Apologies for the confusion," and then went on to give me like an explanation about why it was wrong. So but I caught that because I knew better, right? And if I didn't know better, I may not have caught it. And so I don't know. I think there's still a fair bit of effort that needs a fair bit of refinement before these kinds of AI tools are going to be ready for prime time. I think the way that I've been trying to think about AI is I'm sure at some point there's going to be there's going to come a time when AI can replace what I or my team does entirely. I think we're further away from that than like the AI optimists are, than the AI optimists think we are. But what I think the role of AI is today, it's an assistant, right? Like I think about like it can help me start to do the things that like maybe like a graduate student could have helped me with, like like a master's level student could have helped me with, in terms of finding references, verifying that the information is correct. I don't know. Like I'm trying to think about the tasks that I'm going to be asking AI to do, and there's like a line that I won't cross in terms of asking it to do data analysis on my behalf, and a bunch of like support tasks that probably can happen that aren't necessarily mission critical to the overall project. But again, I'm a little bit of a skeptic here. I think the models will get better. By the way, I sat in on a sales pitch for an AI company that's trying to sell more like analytically focused AI. And the big challenge is that particular tool, I don't even remember the name of it, could only write code in SQL. And I'm like, that's great. If you're an SQL, if not people on your team are SQL, I happen to be a SAS user. My team is made up of people who work in SAS and R, and I got one guy who works in Python who actually the SQL stuff makes sense to. But the point is a tool like that is limited if it can't speak in the languages that the users speak in. And even though SQL is hugely common in data science and data analytics, not everybody works in it. And I think any AI tool that's going to sort of break through in the research space is going to have to speak multiple languages in terms of analytic software.
Well, and also to provide, maybe this is a really ignorant way of putting it, but some sort of statistical, I don't know, percentage of reliability or something along those lines. I mean, if you go through and do the program like we went through and that you actually finished, pretty high level statistics we're doing at the PhD level, and my familiarity, of course, is more with Stata than SAS, but when you look at a data set and you're going to build a model and you're going to apply certain techniques and you're going to correct for certain things, and it's all based in, you feel like, at least I feel like, I'm more in a reality of what is known and what is not known, and at least to be able to put some error bars around it. And I feel like at least the tools that I've been exposed to with these large language models, you don't see much of that. It's just presented to you, here's the answer, in a nice way, until you call it on it. I had the exact same experience, totally different thing, yesterday, working with something, getting it out of, and just using ChatGPT for brainstorming, right? And then it's giving me these responses that sound so very certain, and I know they're wrong. So it comes back to having a level of understanding and of knowledge before you go into something and how you're going to apply those tools. But I don't see a lot, especially in the analytics world. Like, wouldn't you want to see the same kind of, I don't know, statistical confidence or any other, like how it's arriving at the information that it's being presented to you?
A, I definitely want to see that, and B, I think that the further away the analyst gets from doing the work themselves, the further away from analytic decision making, the further away from actually, struggling to get the code right, whatever it is. I actually think that's detrimental because AI may give an answer, but I think the value of the kind of work that you're describing, John, the kind of work that you see in academia, the kind of work that I know you see at various places in industry, um, you get analysts that know a lot about a particular data set or know a lot about the way a particular analysis was set up, and knowing the way that analysis is set up impacts your interpretation of the results. And it's not just the coding, it's everything. It's the decision making that sort of happens along the way. And I have a hard time thinking about sort of an analytic world where, I take somebody from my analytic team, for example, they can code up something start to finish and know everything about it. I really am having a hard time envisioning them working through an AI environment to sort of do the same thing, like cohort selection. I've got I've got observations on a lot of different people, and I have to select which ones are most appropriate for the thing that I'm trying to understand. And when you go through the act of manually coding that up, you make decisions along the way. At what point do I cut off the birthday, right, to age into the cohort or to age out of the cohort? How do I assign if the observation sort of has multiple geographies associated with it? How do I know which one to assign it to? And if I think about all of those things sort of in a stepwise process, I have a hard time seeing my analysts know how to interact with AI in a way that sort of gets them to the same place, as opposed to them sort of struggling through that code on their own. Even though I know AI can write code that would accomplish it, it's the actual act of thinking that my analysts have to go through that actually informs the way that the study ends up getting conducted.
So yeah, Dave, thanks for pointing that out. The way that I like to think about it is, if I'm starting on a project with a data set, I like to look at it as unless it's a huge data set, I like to look at it as an Excel spreadsheet and look for patterns, look for missing data, look for information in that way. And to your point, if you're as an analyst, the more you're separated from that process, the less connected you're going to be, and probably the poorer your recommendations may be, or your analysis. So you got to stay close to it. Anyway, I realize that we're a little bit over on time, so I wanted to say thank you, Dave, again, for spending some time. Love to have you back. It's always interesting. There's always something new to talk to you about. But thanks for taking time out of your day to talk with us, and good luck in your role at the center.
Yeah, and John, thanks a lot for having me on. I'm always happy to chat, and I'll say yes anytime you ask me to come back. So absolutely, thanks a lot.
Thanks. So that'll do it for another episode of Healthcare Rounds. Our guest today has been Dr. David Radley, Director of Data and Analytics at the Center for Evidence-Based Policy. As always, I'm your host, John Marchica, CEO of Darwin Research Group. Do us a favor and leave us a rating on Apple, Spotify, or wherever you listen to your podcasts. And of course, make sure to follow Healthcare Rounds on LinkedIn and YouTube. Thanks again. See you next round.